Okay guys, so we just did Lexus Talks and it looks beautiful. So today we're gonna walk you through doing part 2 of her filler. We're gonna do a little bit in the chin shadow, and a little bit in the lips, okay? So first you can kind of see here, when I do this with her chin, she has some tissue that collapses. So I'm gonna put a little filler here, and then I'm gonna use a cannula, and I'm gonna do some filler in that chin shadow for some support. Her lips are beautiful, but we're just gonna hydrate the tissue and give them a little bit of a lift, okay? Doing a little bit of volume here is gonna really give her some nice support. So first, to make her nice and comfortable, I'm gonna do a little bit of lidocaine with Epi to kind of just give her nerves in this area a little bit of a block. So she'll feel a little stick and a little burn. But again, this area can just be a little bit spicy. So the nice thing to do is give them a little bit of numbing. Okay, so after we did a little bit of a nerve block down here, I'm gonna do a little bit of lidocaine with Epi in the pilot hole to help numb that area as well. That's again more superficial. First injection, I use my pilot hole and my needle. And that lidocaine with Epi is going to really help her decrease the chance of bruising as well. So here's my cannula, and I'm just gonna go in superficial. We're in what's called layer 2. You wanna be superficial when you're injecting here. How you doing, Lex? And right now I'm just subsizing the tissue. So essentially what you're doing is you're helping for the filler to be able to lay down more seamlessly. So you can see my cannula, and I'm just gonna do small little baby aliquots, little linear threads to kind of soften that chin shadow. When you're in layer 2, again, you can see the outline of that cannula. You can come closer. You shouldn't be able to see the color of the cannula, but you can see it. And again, if you're in that chin shadow, you wanna be more superficial. And then when we come in down at the bottom, we'll be on periosteum. But so you can see here, compare this side to that side, how that shadowing is just not as deep. Going in with my introducer, and I'm using a 25 gauge cannula. Again, I'm just using a teeny amount of product here just to help soften her little chin shadow. First, we're subsizing. It's also good too to have your patients Botox this area prior. It's just gonna help that filler lay down more seamlessly. So you can see I use a really small amount of product, like half syringe in that area, but that chin shadow now has a little bit more support. Okay, so now we're gonna do a little bit on periosteum in the midline to help kind of camouflage her cleft. Things we wanna be mindful of, I should have talked about this prior to just injecting her for you guys, but a lot of arteries, especially in the lower face, you have your submental arteries, you have your ascending mental arteries, you have your superior and inferior labial artery, your labiomental artery. There's a lot of arteries, so super important to know anatomy. We'll attach a picture with arteries so you can be mindful of. And then again, making sure you're in the right depth. So if we're in the chin shadow, we want to be in what's called layer 2, which is the subcutaneous, the superficial fat. And then if we're in that midline, we want to be deep on periosteum. If you want the chin to come out more, you're going to be injecting like this. If you're wanting to elongate it, because let's say their first, second, third doesn't match, we want it to be like a cohesive unit, and you need to elongate the face, you can come from underneath. For her, I think she has nice, her 3 medial, upper, middle, lower match. It's more so just to kind of camouflage her cleft. So we're gonna go in this way. I also like to make sure my bevel is down. Go in, tap the bone. You doing okay? Mm-hmm. And then I am using a 1/2 inch BD syringe. I feel like you have more precision that way than using the bigger needle. And I'm aspirating. So essentially that's just where you pull back on that plunger to make sure that you don't have a positive aspiration, which would mean that you are in a blood vessel. And I'll come out, kind of reassess. So you can see it's a little bit softer, but not to like full correction. So we're gonna go back in again. And just because you don't have a positive aspiration, that does not mean that you are not in a vessel, but typically aspirating is about 33% effective. So you have a lower risk of causing a vascular occlusion. So if you can drop your risk by 33%, you should do it. I'm gonna do a little bit more. Aspirate for a good 10 seconds. Oh, look at that positive aspiration. That's actually wild. So what that means, had I injected there, that could have caused what's called a vascular occlusion, meaning not good, a blocked artery. So anatomy is super important, and making sure you see an injector that knows how to keep you safe. So after positive aspiration, you want to obviously come out, not inject, reposition your needle, which I did. I went below that spot. I'm obviously not going to go there. And I'm going to aspirate for a good long 10-15 seconds. Also, always want to be watching for like color changes, making sure the tissue doesn't have any color changes. Also, the patient's comfort level. I always ask them, well, if she's numb, it's harder to tell. But if your patient isn't numb and you hit something and they go out or they flinch, that should indicate that you're probably somewhere you don't want to be, because you can think vein, artery, nerve. So if you're near a nerve, you're most likely also near an artery. I'm actually going to come up from this area. If you guys can kind of see, I'm changing it, but I still want to make sure I'm hitting bone, but I'm just going a little bit lower. With injecting, like, you're going to change your technique depending on like how the patient's looking. You can also do like a little retrograde and pull your needle out to drop that little aliquot. You want to map them out because obviously that's going to give you like your plan, but your plan can change because once you start augmenting the tissue, you have to see how nice does it feel, what are the other features looking like as I'm correcting this deficit or this volume loss. And so you might make adjustments to your treatment plan. To her lips, I like to lay them back, and when you lay them back, you can also see like more of if there's asymmetries and things like that going on. So if you come in and get close looking at her lips, really she's pretty symmetrical. I mean, she has really pretty lips and good tissue. So she will be easy to augment. Everybody has a little bit of asymmetry, but there's nothing that's like super prominent that is catching my eye. And so I like to start with the upper lip, and I like to do what's called a fencing technique, which is where we literally go down and we do a little strut of upward to create like a fence to give her lip more height and support so that it's not just going out. We don't want any duck lips. I have them slightly open their mouth. That way I can see the wet dry border and the anatomy of the lip. I always start with the Cupid's bow. This one's a little bit lower, so I'll start on the lower side and I go right into the pink. You wanna make sure you're in the pink, not in the white. And then you're gonna go down. You should be able to see the outline of the needle, but not the gray of the needle. And what I'm doing is I'm pushing nice and slow, and I'm just gonna be doing a little fence. You can see how it just lifted that up and it filled that lip tubercle. So again, I'm going right next to my fence. Lift up, can see the outline of the needle, not the gray of the needle. The appropriate layer in this area as well is gonna be superficial in layer 2. If you're too deep, you're more likely to have a vascular occlusion, which we don't want. So again, I'm going nice and slow. I'm putting my little fences right next to each other. You can already see how much this side is lifted compared to that side. And she's never had filler before, by the way. Now, obviously, like, we don't want the lip to be like a sausage. So remember, you want to like taper as you go. You want to have more volume kind of centrally. You don't want it to be like a beak, obviously. Pretty lip volume is typically more centered this way and then tapered as it goes out. I'm putting pressure here because I don't want her to bruise, which I like to do that for my patients. Try to have them not bruise. Obviously, it's possible with a needle, but we want to be nice and, give them the best result we can. Make sure you send them home with an ice pack. So we'll do the same thing on this side. Make sure we're in the right depth. Inject nice and slow. Drop on the border. You can see the lip starting to fill. I like to take my finger and kind of curl the lip up so that I can more easier access that border. See how that makes it so much easier to go in. Again, I'm doing a nice, slow, little linear thread. You can see now she has more border definition. Beautiful. So now I'm gonna move on to the bottom. Again, I like to set them up for this part. You can see it doesn't have a lot of asymmetries going on. Same thing like I did with the top. I'm gonna use my other hand to kind of support and bring that tissue down. Go in at a superficial depth, layer 2. And I'm really just trying to evert her bottom lip. So that's why I did a few passes, leave a tiny little drop on the border because her teeth, her bite, kind of have her lip back. Do you have an underbite?
I think like a little.
A little bit, yeah. So again, it's really important to like pick up on these things because if your patient's teeth are not completely straight or if they have an underbite or an overbite, these things can obviously affect the outcome. So I'm, want to project her bottom lip because I don't want her top lip to be overpowering her bottom lip. So again, I'm really trying to curl this out. and keep the volume more central. So one other thing I'm gonna do to really kind of help this bottom lip curl out like we want to, I just did my fences down, but now I'm actually going to take this hand and kind of hold it in the middle to help me get my needle where I want it to be. And I'm going to like do a little thread kind of rounding out that bottom lip tubercle. So you can see that. I'm gonna do it on the side too. Again, keeping the volume nice and central and doing a nice little thread. We're also gonna put a little in the tubercles itself. So we really focused on kind of like the border. So open slightly for me. Now this is where I'm going in the tubercle, doing a little linear thread. So again, using this hand to kind of avert and give me support. And then I'm going to go in like this, okay? I felt like that side was it was a little bit not as lifted. So that's why we did that. I'm doing the lip tubercle, so I'm using this hand to help support, going in, and then kind of what we also talked about, be mindful of anatomy. So you're thinking superior labial artery here, inferior labial artery. So again, sometimes you can see, whenever I'm injecting lips too, I'm always looking for that. I have had some patients where their arteries do run more superficial, and you can literally see them pulsating, and you really want to avoid that, obviously. So if you see any pulsating artery, then you would want to obviously avoid that. But usually it's going to run deeper. So again, making sure you're in that superficial layer, making sure you're aware of the arteries within the lip, and then, you know, avoiding them as much as you can. I don't aspirate in the lips. Some injectors do. I don't think it's bad if you do. I don't think it's bad if you don't. I think you are constantly moving your needle, your superficial, assess for arteries prior, and those are a few things you can do to be safer to avoid an occlusion. So over here, she just has a little bit of like dryness and it kind of tucked away. So I'm just gonna like do a little baby bit to hydrate that tissue. Her cleft is much softer. Her lips are nice and hydrated. Chin shadow is much smoother.